All right. We're moving on to Topic Tuesday. All right. This is not a post from me. I'm not sure if it's Adam or Duke, but we're going to find out. All right. What's up, family, is what it says. I hope you're all doing well this lovely Tuesday morning. Welcome back to another week of Topic Tuesday, where we're really going to be learning something new together. And this past Topic Tuesday was really focusing a little bit more about aortic valve disease, which can really happen to any of us, unless, of course, you have a bicuspid valve. You're born with that. That's considered more of a congenital heart defect. So again, you don't develop a bicuspid quadcuspid. You don't have a difference in cusps that you develop. That's something you're born with. And specifically, this post was honing in on two different types of issues with valves and the types of valves that can be used to replace or repair them, okay? Because we get a lot of questions about this as well. So here's a brief review, the two main types of aortic valve disease that we've talked about in previous weeks. And the first one was stenosis. Do we remember what aortic stenosis means? Aortic stenosis means that the valve is too tight and the valve is hardening. And this can happen as we age. It's pretty normal for that to happen to some of us. And that really happens because of a deposit of calcium and fats and cholesterol along the leaflets that are in your valve, and it causes it to harden, and it causes it to lose its ability to expand. And we need these leaflets to be flexible and to move. And stenosis can happen in any part of the vascular system. A vein can get hardened, another artery can become hardened, can have deposits, it can become blocked. And we don't want to lose that flexibility or sponginess, which is why a lot of you are on valsartan or losartan. I believe that's the ARBs. Those medications, and I could be wrong, but those medications specifically help keep flexibility in your valves, not valves, in your arteries, in your veins. Okay, so here's a picture of stenosis. So here you have your aortic valve. This is your left ventricle. There's your aorta, right? And this is what a normal aorta is going to look like. These are actually your three leaflets, your three cusps of the aorta. Here it is with all these icky deposits, blah, 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 right? This is going to cause a little bit of this is your stenosis. This is hardening. It's not coming together very well. It's not coming together tightly. There's also aortic regurgitation. So that's floppiness of your valve, right? It's too loose. And it means that the valve is not tight enough, so it's going to let flow of blood to go backwards or regurgitate, and it leaks backwards goes into the heart with each beat due to an inadequate seal between the leaflets, which I was just mentioning. So here we go. Here's your blood flow going up into the aorta, but if it's floppy, it's going to come back down into the heart. And this regurgitation comes in different degrees. And all your valves have an opportunity. Your mitral valve, your pulmonary valve. I think the other one is tricuspid valve. I think that's the right word. I'm tired, people. But let's talk about the aortic. Any of them can have a degree of regurgitation. It can be trace, mild to moderate, moderate to severe, and severe. So I don't know the different percentages for all of them, but I'm at moderate, and I have almost 40% regurgitation back into my heart with moderate, not near having any surgery at all, not even close to it, which kind of sucks because I have symptoms. I have some shortness of breath, a little bit of fluid retention, not bad at all, but mainly a high degree of shortness of breath and some other funky things that we believe it's because of the valve. But that's what happens when you have aortic regurgitation. And again, this can happen in any of your valves. So we don't tend to talk about mitral valve or a prolapse or something like that, because that's really very specific to the heart. Aortic valves are specific to the heart, but they can impact our aortas. That's why we talk about the aortic valve. Okay. When it comes to replacing your aortic valve, there's two options. And you can have a mechanical valve. We talk about this all the time. It's made of a metallic material, or you can have a bioprosthetic valve, which is made using animal tissue. And that's either pig or cow tissue. Okay. And each of these different types offers their own benefits, kind of also offers what you might view as a con. So a mechanical valve is made out of non-immunogenic, like I got that word right, I think, metallic material that's designed to decrease the risk of your body forming a reaction to it. So you're not going to reject a mechanical valve. You don't have to worry about taking really with either of these, any of these, any type of anti-rejection medication, but you're not going to reject or have an issue with the mechanical. They're considered actually to be the most durable type of valve and the most long-lasting type of valve. We usually hear people say it's a one and done, but they can pump for 20 to 30 years before they even possibly begin to wear down. So it is really a primary choice for people in younger patients, and younger, they say 50 to 60-year-olds. So it is a nice thing to read when I'm in that bracket and I'm considered young when you're talking about valve replacement. But let's just say anybody 60 and under, they're going to want you to consider getting a mechanical valve, because that hopefully should take you through the rest of your lifespan. Okay. However, the main drawback of utilizing a mechanical valve is that you need to be on a blood thinner for the rest of your life, specifically Coumadin, or otherwise known as warfarin. And this is to make sure that you don't develop any type of blood clots on the metal surface. All right. So that's something you have to think about. And I also hear that a lot of people talk about they can hear the click, clack, tick tock of this valve. So if you're somebody that you think this is going to make you insane, I also hear that people get used to it. So that's something to also consider. But the blood thinners is a big thing. And this is really a personal choice when it comes to thinking about what type of valve you want. And you also need to consider the lifespan of the valve. And we're going to talk about that in a minute. Here's a mechanical valve. Here it is. This is the suture ring. So they put this in place of where your aortic valve is, and these are actually the leaflets. Interesting, right? Because we're born with 3 leaflets, unless you have a bicuspid, but this kind of looks like 2 leaflets. So I don't even get it. How we take out a 3 and we put in a 2. And it doesn't even look like triangles. It looks like my air conditioning ventilation duct. I don't get it. I don't know which direction they swing. I can't wait to see it in person, but these are the hinges. I'm guessing they open and close like a bar door or something. I don't really know, but I just find it fascinating that this is what is going to potentially take the place of your natural valve and, allow you to just keep ticking. It's amazing to me. But alternatively, patients can also consider a bioprosthetic valve. And once again, these valves are non-immunogenic, meaning the risk of you rejecting them is very low due to the way that they're designed. So these valves have a lower risk of thrombosis, or its blood clot. Okay, so they already carry a low risk of blood clot. So you do not have to be on a blood thinning medication like warfarin, or otherwise known as Coumadin. You don't have to be, because when you have a tissue valve, it's not going to allow clots to form on the tissue. However, unlike their mechanical counterpart, bioprosthetic valves, they're more susceptible to a calcium buildup over time. And the natural aortic valves leading to a premature structural valve deterioration. Okay, that's that word for you. All right, their durability is estimated to be between 10 and 20 years. So you're not going to get that one and done lifetime situation. It's only going to last anywhere from 10 to 20. Some people hear 10 and 12 or 10 and 15, but I know many that are way over the 15-year mark, and they're doing just fine. So this may or may not be an issue when it comes to elderly patients. That's the 60 to 80-year-old group, sorry. And whose expected life expectancy is within that range. However, younger patients who undergo bioprosthetic valve replacement and outlive their valve, they might need a second valve replacement within their lifetime. So let's think about this again. So if you are 60 to 80, getting a valve replacement is not really considered an issue, because it probably will take you through the rest of your life. But if you're a younger patient, it's pretty highly likely that you're going to need to have a valve replacement at some point in your future. So if you're 35, maybe getting a tissue is not going to be the best thing for you because you're probably going to need to have another one, which isn't a problem. They don't need to do open heart surgery. They can literally deploy a new one by going up your valve and going up your groin, and that's an endovascular. But we'll get into all of that another time. So here's some of the tissue valves, which I have seen some of these in person, and these actually have what look like three cusps. So this is one by Edward Life Science called the Magna Ease. Medtronics had something called the Hancock 2 sitting here. St. Jude has Trifecta, and I have not heard of the Soren Group, and this is MitraFlow. So these are tissue valves, and I'm going to go look at them at some more of the conferences. I actually would like to try to pretend I'm doing surgery on something. I'm going to go look at these and touch them. Both types of valves, regardless, have been extensively researched, and they function very well doing the job of an aortic valve that you were born with, and that is to open and allow the blood to flow, enter the aorta, and supply the rest of the body with that blood. But they also need to close while the heart is filling. To make sure the blood doesn't leak backwards. So there's a whole open reason to send the blood on. There's a whole close to allow the heart to flow. If you or a loved one are planning to have aortic valve replacement, you really have to discuss these different options amongst yourselves, and with your surgeon and with your cardiologist to figure out which option is going to be the best for you. This is one of these situations where, unlike an emergency dissection where we don't have a choice on the manufacturer of our grafts or which ones they use, this is something that takes time, and you really want to talk to other organizations about this. I mean, Rock from the Heart is one that really focuses their attention on aortic valve replacement. And so that's another place that you can turn to outside of Aortic Hope to ask these questions and just find out what everybody's personal experiences have been. And because, saying to your surgeon, what would you tell your mother to do, or your sister, or a friend in my, you can't really get, I think, you just can't get a decision that's where they're not adding their own medical knowledge into it. And I can't think of that word, but you know what I mean. So I think do the research and make some personal choices based upon what you find out. I know for me, I am not going to go mechanical as of today because I can't live with the TikTok option, and I don't want to be on blood thinners. So I will make that final decision when I find out that if I, at age almost 55, take a bioprosthetic, if I take a tissue valve, if it lasts me 15 years, so I'm going to be 65. Are you saying I'm going to, or I'm going to be 70? Am I going to need another valve? Well, what does that mean? Can you deploy another tissue valve easily through the groins? If you can, great. I'm going to do it. Plus, I don't know what advances are going to happen in 15 years. I look at just the last 9 years, and I'm completely mesmerized at all the changes. But I don't want to have two, because if I'm 70 and I get one, what if I need one in 85? Like, will I care? I don't know. Who knows? But this is why I'm trying to hold off on having one. The further I can punt this down the line, the easier it'll be for me to choose tissue. Because 95, I'm not thinking I'm replacing anything, and you only get to replace what's in there once or twice. I think you don't get to just deploy new valves 3, 4, 5, 6 times. Then you have to cut something out because it deploys right in the place of the original one that you put in. So there's a lot of things I have to think about. So I'm sure there's a lot of things you guys have to think about. And I'm sure a lot of you watching this, I would love to hear what you have to say. How did you make this decision? What was it based upon your lifestyle? What led you to make the decision that you did for your type of valve? I think it would make for good conversation.